Hello, my name is Dr. James Song. I'm a dermatologist at Frontier Dermatology based in Mill Creek, Washington, and I'm coming to you from Scottsdale, Arizona at the 2024 Elevate meeting. And I had the chance to speak on why our older traditional immunosuppressant agents are still relevant for us in 2024. So I focus mostly on methotrexate because that still is kind of my workhorse. I'm actually using this drug almost every single day. And so I just want to kind of give you a couple of tips here as how I use it and what are maybe some of the ways that we can improve patient adherence. So when you actually look at methotrexate, the data is actually pretty good for psoriasis. Maybe not quite as good as the biologics, admittedly, but it's still not bad, especially for some of our older patients. I found you don't actually need to give them that much of methotrexate to get a good response. I've actually found it to be actually quite helpful for psoriatic arthritis as well. Maybe not quite as good as our biologics again, but still very much respectable responses. And I really like it as a way to kind of salvage or boost the effect of other biologics that a patient may be on, maybe for a different indication. So if a patient is on a TNF inhibitor, for example, for Crohn's disease, but their psoriasis is flaring and their GI doesn't want them to switch off of their drug because it's controlling the Crohn's, add methotrexate. It's a great way to kind of boost that efficacy. I also like it for patients who have maybe just kind of dermatitis. I'm still trying to figure out what that actually is. Is it atopic dermatitis? Is it psoriasis? Is it smoldering CTCL or PRP? I don't know. It's okay because methotrexate actually treats a lot of these conditions. And so this is kind of my go-to. Or patients who have pure palmoplantar psoriasis. They don't have psoriasis elsewhere, just on the hands and feet. Biologics just don't work all that well for this population. And until we've got the JAK inhibitors, which now for me is kind of my preferred treatment for these patients, methotrexate has been my long go-to medication for this population as well. We also talked about data for alopecia totalis and universalis. There are some patients that just aren't candidates for JAK inhibitors. Methotrexate is actually quite effective if you could get the dose high enough to like 25 mg per week. But when you look at the SALT to 10 score, right, which means only 10% of your scalp was bald, that's a very high endpoint. We're seeing about a third of patients getting there. That would rival what we're seeing with some of our FDA-approved oral JAK inhibitors. Now, one of the issues with methotrexate, admittedly, is going to be the tolerance. People have a hard time tolerating the drug, but also the differences in how we're monitoring these patients. And for some people, it could be a little bit onerous of how often we have to check the medication or check the blood work. When do we have to do a liver biopsy? And so these are things that are kind of scary for our patients and for us as clinicians. So I just want to give some updated guidelines as to how we should be monitoring these patients and also dealing with some of the side effects that patients get. So let's talk about the side effects. If you're going to get something, it's usually GI or neurological in nature. So my approach to this is if someone already has baseline dyspepsia or nausea, or they tend to get headaches, I'm just going to give them folic acid 5 milligrams right away on every single day except for the day of methotrexate. If that doesn't work, I will add glucovorin, which is a more bioavailable form of folic acid. On the day of methotrexate, I'll wait about 8 hours after that methotrexate dose, and I'll repeat it again in another 8 to 12 hours, and that really does help. Also, cacao, caffeine, dark chocolate, these are great ways to help with some of the GI side effects. We think some of that has to be due to increased adenosine levels from methotrexate. So these are all actually natural adenosine receptor blockers. So I tell someone, take a cup of coffee with your methotrexate, take it again later in the day, and take it once more the morning after. And you can do that with dark chocolate too. 4 bars of dark chocolate is about equivalent as far as the amount of caffeine or cacao that you're getting. If that doesn't work, change to sub-Q methotrexate. That's actually been the most effective thing for me. You get better bioavailability, and the nausea, the diarrhea, I feel like that just goes away for the most part with the sub-Q formulation. Now another, I would say, lesser known side effect for methotrexate is some of this, what we call the blahs. You take methotrexate, you're just like, I feel tired, I just don't feel like doing anything, I get mental fog. And it turns out that's probably because methotrexate increases what we call homocysteine, and that gets converted to homocyteic acid, and it binds to the NDMA receptor, and that's what causes these neurological sequelae. So actually, if you take dextromethorphan, believe it or not, it actually competes with that NDMA receptor, and it makes a lot of these patients feel just a lot better. They pep up with it. So what I typically do is I'll prescribe methotrexate and folic acid like I normally do, and I'm going to just prescribe the Mucinex DM. It has dextromethorphan in there. Take it the day of methotrexate and take another dose the day after, and that really helps as well. What about starting the patients on methotrexate? Do I need a test dose? The answer is no. For the most part, 15 mg per week is the standard dose for pretty much all of my patients. Now there are certain types of patients you want to be a little bit more careful of. If they have chronic kidney disease, they're older, they have chronic heart failure, or let's say their platelets are already kind of borderline low, or they're on a lot of other medications that could raise the levels of methotrexate, maybe I'll lower the dose to like 10 mg per week, but I would say the vast majority of my patients are at 15 mg per week. How often do we have to check labs? The data suggests that you're really not going to get any clinically meaningful lab changes right before 2 weeks. So probably 2 to 4 weeks after you start methotrexate is a good time to check. And every time you increase the dose of methotrexate, I'll check it maybe a month later. And once you're at a stable dose, you really don't have to be checking it that often, maybe every 3 to 6 months. Do we need to do liver biopsies? Well, according to the older guidelines, once you've reached 1.5 to 3 grams of cumulative methotrexate, you should get a liver biopsy. I mean, if there's one way you could convince a patient not to take methotrexate, it's scare them with a liver biopsy. We do not need to do that anymore. We have updated guidelines from the AAD saying that, look, for the vast majority of these cases, you could just order a blood test, a non-invasive serology test that will give you a risk score of essentially your liver health, right? And if you have, I would say, a fibrosis score that is mild or moderate, so F1, F2, you're okay to start methotrexate, and I'll just repeat that test every year. Now, if you have a higher fibrosis score at baseline, let's say like an F3 or F4, those are the patients I probably wouldn't use methotrexate unless I didn't have any other options. We also talked about non-invasive imaging as a way to monitor patients who are on methotrexate as well. It's pretty much like an ultrasound. That could also be a nice way to complement the blood test as well. So really, you do not need to be doing liver biopsies for the vast majority of your methotrexate patients. So just to recap here, if you're going to start methotrexate, 15 mg per week is probably going to be fine for the majority of your patients. Check those labs maybe 2 to 4 weeks after that first dose, and then you could check it every 4 weeks until you get to a stable dose. After that, you can just monitor them how you normally would. I forgot to mention, make sure you order that blood test. It's called the NASH fibrosure at the very beginning, and then I might check it once a year while they're on methotrexate. Hopefully you found that useful. Thanks.